Quick summary of a neurological exam. We'll start with cranial nerves, upper limb neurology, lower limb neurology, and a few special tests at the end. So cranial nerve 1 is your olfactory nerve. So ask the patient about sense of smell. Cranial nerve 2 is optic nerve. Several things can be checked. You could check the visual acuity, color vision, accommodation reflex, light reflex, fundoscopy, field of vision. Now, when checking field of vision, you could ask the patient to point towards which is moving. You can also test both at the same time, which would check for inattention. That would be the sign of a cortical lesion in a non-dominant hemisphere. Of course, with a pupillary reflex, optic nerve, cranial nerve 2 has got the afferent pathway, while the efferent pathway, i.e. the pupil constricting, would be cranial nerve 3, oculomotor. So moving on to oculomotor 3, trochlear 4, and abducent cranial nerve 6. Those three are tested together. So ask the patient to keep his head still, follow your finger with his eyes, and in a classic H-shaped configuration, you would move your finger about, looking for any nystagmus and asking the patient to report any diplopia. Cranial nerve 5 is trigeminal, which is primarily sensation of your face, which you would check. Also, it innervates muscles of mastication. So ask the patient to clench the jaw, check for the masseters and the temporalis muscles. And also, if you're suspecting pathology, you could do the jaw jerk. An exaggerated jaw jerk would be a sign of pathology. Moving on to facial nerve, which is cranial nerve 7. That innervates muscles of the face. So you would ask the patient to close his eyes, puff the cheeks out, show you his teeth. It also innervates lacrimation and salivation. So you can ask about dry eyes or a dry mouth. Facial nerve also provides sense of taste to the anterior 2/3 of the tongue. So you can ask about a loss of taste there. And facial nerve also innervates the stapedius muscle. So patients with facial nerve palsy can get hyperacusis or louder sounds on the affected side. Cranial nerve 8 is vestibulocochlear nerve. So you can test hearing, and you can also check the vestibular function by asking the patient to close his eyes and march in one spot. Cranial nerve 9 is glossopharyngeal, cranial nerve 10 is vagus. They're both tested by asking the patient to open his mouth, say ah, and you're looking for the palate to move up, and you're looking for the uvula to stay central and not deviate on either side. You can also ask the patient to say ka ka ka, which is a palate sign. While you're doing that, you can also ask him to say ma ma ma, which is a facial nerve sign, so cranial nerve 7 there. And you can also ask him to say la la la, which is the tongue, hypoglossal nerve, cranial nerve 12. Cranial nerve 11 is a spinal accessory nerve, which innervates the ipsilateral trapezius muscle and the contralateral sternocleidomastoid muscle. So movements of the shoulders and rotatory movements of the head. And finally, hypoglossal is cranial nerve 12, which is essentially tongue movements. That finishes off cranial nerves. Now, upper limbs. You can start off by looking at the limb, look for any fasciculations suggesting lower motor neuron lesions, and look for any signs of atrophy. You can also check the tone, and you can also check for clonus. Sensation would be C5, C6, C7, C8, T1. Power would be shoulder abduction, C5, elbow flexion, C6, elbow extension, C7, finger flexion and extension, C8, finger abduction and adduction, T1. Reflexes, biceps, C5, brachioradialis, C6, triceps, C7. You can also check proprioception and you can check vibration. Lower limbs similar. Start off by looking for fasciculation or atrophy. You can also check tone by doing a leg roll and just by pulling the knee up and looking for the floppiness of the leg. Sensation L1, L2, L3, L4, L5, S1 at the bottom. Power, hip flexion at L2, L3, knee extension L3, L4, foot dorsiflexion L5, S1, foot plantar flexion S1, S2, reflexes, knee reflexes L3, L4, ankle reflex L5, S1. You can also check proprioception and vibration sense. Moving on to some special tests now. 2 tests you don't want to forget in cases of meningeal irritation, either suspected meningitis or subarachnoid hemorrhage, is the Kernick sign and the Brudzinski sign. 3 tests that you can do with the upper limbs are rapid alternating movements, so looking for dysdiadochokinesia, sign of cerebral disease. You can also ask the patient to close his eyes with his arms outstretched, looking for a pronated drift. That can be a sign of a subtle upper motor neuron lesion. And you can do a fingered nose test. Past pointing can suggest cerebral disease. And there are 4 tests you can do with the patient standing up. You can ask him to walk heel to toe, like a tightrope walk, testing cerebellar function. You could ask him to walk on his tiptoes and then walk on his heels. A good test for power in the lower limbs and extrapyramidal function. And you could do a Romberg's test. Swaying or imbalance with the eyes open will suggest cerebellar disease, while swaying with the eyes closed would be more suggestive of pathology with proprioception.